So we'll go ahead with our last presentation, introducing Jonathan Bacon, who is the Interventions Coordinator at Clinique Médicale L'Actuelle, where he has the pleasure of developing intervention programs and coordinating the clinic's psychosocial support team. His past experience as a street-based outreach worker has given him increased interest in issues surrounding sex work, housing insecurity, and PNP. In his spare time, he is also the president of CRIFAS, an organization that provides support to men who've experienced sexual abuse as children, and he's completing a specialized graduate program in law and health policy at the University of Sherbrooke. Jonathan, the mic is yours.
Thank you, Patrice. Okay. Hello, everybody. Thank you for having me. I'm very happy to be closing this roundtable. And everybody, please cross your fingers for the stability of this PowerPoint. Thank you. So first things first, I do want to mention, yes, that the programs I'm going to be discussing today were funded in part by these 3 pharmaceutical companies. And it's actually been pretty great to see them aligned behind caring for chemsex users. So my plan, hopefully for the next 15 minutes, is to start with some quick facts about L'Actuelle and what L'Actuelle is. Then I'll go a bit into our psychosocial response to the COVID-19 pandemic. I do want to take a few minutes after that to talk about other PNP initiatives in Montreal, followed by, well, what our program basically looks like. And then I'll show you some results and outputs from our first year being operational. And I'll close on some challenges and opportunities for growth that I've identified. And I've identified quite a few, so I cut them down. So L'Actuelle, it's a semi-private family medicine group founded in '87 by Dr. Thomas. Being semi-private basically means that sometimes we're scrambling for cash, but otherwise we're more flexible in our interventions, so it has its ups and downs. We're specialized in prevention, testing, and treatment of HIV and other STBBIs, and I would say general queer healthcare. In an average week, we have over 1,000 appointments at the clinic, adding to that 150 walk-ins. As of early 2022, we had over 4,000 patients on PrEP receiving services at the clinic, and as of the second quarter of 2022, we have over 1,600 patients living with HIV at the clinic. And very recently, we had about 1/3 of the province's monkeypox cases, so go us, I guess. When COVID hit, we actually stayed open. Most other clinics in the village and in Montreal decided to start seeing their patients online, and we stayed very much open. The most of online consultations we had was in October 2020, when we had about 14% of online consultations, so the number has stayed very low, and we're happy about that. Staying open allowed us to keep an eye to the ground, and we began to hear increasing anecdotal reports from our medical team of changing psychosocial needs or changing substance use patterns. Some people were increasing their substance use, others were changing the substances they were using. And so very quickly, we decided to set up some projects. The first project we set up was funded by VIVE in the summer of 2020. Its aim was to evaluate the mental health of our older patients living with HIV during early confinement. And the mental health numbers were a bit alarming, and again, we received anecdotal evidence of changing patterns of substance use. So our second project, funded by AbbVie, which finished very recently, was to explore Hep C vulnerability in our patients who party and play. And while the Hep C intersection was not very conclusive, we needed more data, what we wildly underestimated was the big need for individual support. Our initial goal was for our peer worker and project manager, Jean-Sébastien, to start seeing patients after a few weeks on the job, and in reality, he started seeing them on his second day. So yeah, that was an underestimation on our part. And AbbVie basically set the grounds for what we have today as a team, so I'm very thankful. But before I get into more detail, other things happened in Montreal before we did anything. So L'Actuelle didn't develop anything in a vacuum. And if I'm forgetting any projects, I apologize. You can correct me in the discussion session. So around 5 years ago, I think, Réseau had Métamorphose with the University of Sherbrooke. Métamorphose was a research project that was intended to assess the situation regarding crystal meth use in Montreal, both through an online questionnaire and through interviews with public health professionals and with users themselves. Maybe 1 year after that, our local public health put together a chemsex 101 training with a bunch of community members that is unfortunately not being given anymore, to my knowledge. The AIDQ, or the Association for Addictions Counselors of Quebec, also put together Intersection, which is an online community of practice around sexualized drug use. And it's actually being relaunched soon, so if you're in Montreal around September 29th, you can look at their event. It's everywhere on Facebook. Vincent spoke about Contact a bit earlier, so I'm not going to repeat anything that he said, but I do want to add that they sell wholesale-priced sex toys, which could be very interesting. And since COVID, a few more things happened. So first, a citizen initiative called Ça prend un village was put together. Ça prend un village is it takes a village. Their goal was to, do exactly that. So build a village of people in recovery and teach people in recovery how to build their own village, where in this sense, the village is the recovery ecosystem that surrounds you when you're trying to be in recovery. It is as much your nurses, your doctors, your friends, but also your books and your TV shows that help you through your recovery, and it's a tool that we're actually going to get back to later. And finally, very recently, Réseau and ACCM put together the Impact Project, of which I see one representative here, so I'm very happy. The Impact Project, its goal was to offer group support session in a drop-in format, as well as harm reduction workshops where the topics were chosen by the users themselves. And their groups are called PNP for Pour Nous Parler, which is a genius pun that unfortunately only works in French. Now, this slide, I really wanted to do it for two reasons. First of all, it's important, I think, on days like today to recognize the work that others are doing and not just us in our clinic, but also to show that we didn't reinvent the wheel when it comes to caring for our patients who PNP. What we did, however, was, well, hopefully find something that works for our patients, but also that works for us, being an old clinic that's at the intersection of clinical care and community care. We're very much grounded in harm reduction, and my entire team comes out of harm reduction organizations, so I think we find it very hard to do anything but that. So what the program looks like for our patients, or the patient pathway, thankfully it's very short because graphic design is not my passion. See, we have integrated breaks in our presentations, isn't that great? So when we get references either internally or externally, we first meet the patient, ideally within 2 weeks, for a short needs assessment, which is an opportunity to look at the urgency of the situation, first of all, but also get a better feel for their needs. Then after this assessment, we can do two things, and we often end up doing both. So a lot of our patients have specific needs that require specialists, like psychiatrists, psychologists, or medical detoxes that internally at the clinic we can't provide, so we refer them to those services. And internally, support with our psychosocial support team. What that is, basically, and it's not written here, but it's fairly important, it's a free service. Through 5 different workers. We're available through text, and I put this in bold because it might seem obvious to some of you around the room, but it took us a while to understand that it's much more efficient to reach our patients through text than trying to call them, so we're very happy about that. We have non-medical counseling spaces, so we rented a few rooms below the clinic in nicer rooms, that we decorated, and we have sofas instead of medical examination tables, so it's appreciated. Yeah, exactly. We use loose counseling structures, so some patients stay with us for 1 session, others stick around for 20 sessions. There isn't really a hard limit yet. We use motivational interviewing skills, so patient-dictated goals, but we're oriented towards recovery, and this is just something we've learned over the last year. I'm not sure if it's because of the fact that we're in a clinic, or maybe it's our approach, I don't know, but when people sit down with us, they tend to be either in a process of trying to stop using or are seriously thinking about it. The last point here, facilitation with the medical team, is very important. It's something we do a lot of. Sometimes it feels like our medical staff and our PNP people speak different languages, and sometimes they actually do. But basically, this accompaniment, this facilitation is to make sure that the patients maintain a positive relationship, not just with us, but with the clinic as a whole. And what that looks like can be like a 5-minute appointment before their medical appointment, and then a 5-minute appointment after their medical appointment, or we just literally go in the examination room with them. So After a year of existence, we've managed to support, this is actually 11 months, 140 patients who party and play have received counseling for almost 500 hours of in-person sessions. Of these, I want to draw your attention to the last point about prep, because I'm going to come back to it later. And I do want to say that almost all of these hours were done by our PNP project agent and peer worker, Jean-Sébastien, who's actually left L'Actuel recently for the greener pastures of Gilead, and I really do want to thank him for his work. And this is very exciting to me, because if this is one person working for a year, being now that in year 2 we're 5 different people working on this project, I'm very excited to see what else we can do. Now, outputs beyond results. So we put together 3 tools that we can use with our patients. The first of these is this checklist. So it basically summarizes what to do, what to throw away, what to expect, what to delete from your phone, to prepare yourself for a period of sobriety. E-boy. Same in it. This tool is very much appreciated by our patients. The second here is a fairly standard usage tracker or a calendar, but on the flip side, it has more elements, like how much did you plan to spend versus how much did you actually spend? Did the binge have any negative impacts on any parts of your life? How much fun did you have, like on a scale of 1 to 10, you know? So it's very useful as a reflexive tool. The third here, I spoke about the village or the recovery ecosystem earlier. This is a paper version of this tool. So it teaches our patients how to map out the recovery ecosystem, and we encourage them to actually draw it out on the blank side of the paper. This one is harder to use. I think it requires a bit of a step back from our patients, but it can be very productive when it's done. 2 more things that came out of the project for the first year is a PNP training for health professionals. In its a very ideal form, it's in 3 parts, which includes a mandatory viewing of a documentary. The second part is more informative, and a third part is more practical with case studies. The training is built in collaboration with our long-term partner, Maxime Blanchette, who's actually presenting later today. The last big output, and the namesake of the presentation, is the cri de ralliement, or the rallying cry. So it's a working group built of over 25 people who work in PNP care. We have peers, community workers, doctors, nurses, social workers, sexologists, and administrative staff. The group has met twice already and will be meeting again in the fall. It has many purposes, so as we know, a lot is being done in Montreal, but we don't necessarily know who's doing what. So this group is an opportunity to figure out who's doing what and to actually map out the services. It also has an auxiliary benefit of making service providers feel less alone. So we've found that a lot of service providers in PNP can find that it's very hard work and feel like they're alone in doing it. And well, this group is basically a very solid reminder that they're not alone and that, you know, other people are working towards that. And the final objectives, I'm going to have to scroll down my presenter notes here, so hopefully it still works after that. Oh, right, advocacy tool. So the simple fact of us meeting twice has already attracted the attention of the public services that we speak about in our meetings. And so I'm very happy to say that we'll be able to collaborate with those public services in the few coming months to make sure that our patients face less challenges when they use these public services. The first challenge we noticed is that, well, there's a few things that weren't helping the medical community to integrate a psychosocial approach. There's a lot of structural limitations in standard medical care that complicate the provision of services for people who PNP. Big example is the fact that you see a different nurse every appointment, or that you have a fixed, very short time slot where you have to fit everything that you want to talk about with your doctor is a very big limit. Many people who party and play will need several meetings before they even think about talking about their drug use with their health providers, and some people will never do it if they fear being the slightest bit misunderstood. So we do have to work around that. And the short medical appointments are also not useful for a population that often has other contingent issues, right? Mental health, HIV, Hep C, sex work, immigration, gender transitions, all these things can and should be able to be discussed in these meetings. And a big part of the facilitation that I mentioned earlier between the medical team and the psychosocial support team is to compensate for this challenge. So to make sure that our medical care is modeled in a way that makes sense for our PNP patients, and we mostly do that through very extensive communication. The second challenge is a bit more surprising, at least to me, and maybe it shouldn't have been, but it's stigma within care structures. So we've learned that even in a community of allies and or of queer staff members, the very complicated stories of people who PNP could trigger resistance, judgments, or what I call anecdotal sensationalism. So the retelling of stories during lunch hour that starts with, oh, you'll never believe what my patient told me, that I'm sure, unfortunately, a few of us in the room have heard before. And the way we're dealing with this is to do more work upstream to make sure that not just knowledge, but also attitudes of our medical team are, well, in line with what we're doing at the clinic. And finally, this third is very much connected to the second, but in many cases, we found our team to quickly fall into emergency mode when PNP or crystal come up, and we tend to over-evaluate the risks to our patients and treat everything as an emergency. So a big example of this, for example, is if a patient mentions crystal to the nurse will run to our offices and say, this patient needs to go to detox right now, when this is not something that the patient has ever expressed, you know? And when we treat situations as emergencies, what we're doing really is reducing it to a time-bound need, right? You're also stripping away a lot of the creativity you can have in your interventions, so we need to fight against that a lot. And there isn't really a magical solution to this challenge, I think. The solution is generally chilling out, giving tools to your team so that they don't feel rushed in their interventions, and checking yourselves to make sure that you're not pushing your own goals onto your patients. And finally, some opportunities for interventions that I've identified are, and there's a few I could talk about, a more frequent integration of PrEP. So I mentioned earlier that only 27% of our patients for the first year were on PrEP, and to me that feels a bit low. There might be other factors to think about. I don't know, probably there's barriers to access that we're not thinking about, but I'm curious to see what we can do in the coming years for that. We can certainly do better, more pointed interventions with patients that are, this says at risk, I'm not sure at risk is the better word for it, but patients who express curiosity about chemsex or crystal meth, or who may be more exposed to it through social circles. I feel we could do more to give them information before they try it for the first time. And finally, a big thing is better, more sensitive screening by our medical team. They're already doing much better than they were a few years ago, to be honest, but there is definitely more we can do to make sure that when our patients mention PNP or mention crystal or mention any drug at all, that they're heard in a more welcoming way. One last thing, the organizations that I mentioned earlier in the list of things in Montreal, if you want to get in touch with any of them and you're not sure how to do it, please contact me and I'll be glad to facilitate the connection. And that's it for me.